Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Welcome. This is your host, Tom Urochi, and today's topic is prostate cancer, which is, if you take out non-melanoma skin cancer, the most common cancer among men in the United States and probably globally. Our guests today are all experts in this area, and so why don't we just take a moment for introductions. Dr. Agarwal?
Hi, very pleased to be here. Dr. Niraj Agarwal. I'm a geomedical oncologist and a professor of medicine at the Huntsman Cancer Institute, University of Utah.
And Dr. Mal?
Hi, Judd Mal here. I'm a urologic oncologist at the Duke Cancer Institute in Durham, North Carolina, professor of urology at Duke University. Delighted to be here.
Great. And last but not least, Dr. Smith.
Hi, I'm Matthew Smith. I'm a medical oncologist, the director of the GU Malignancies Program at Massachusetts General Hospital Cancer Center in Boston, and professor of medicine at Harvard Medical School. Happy to be here.
Great. Well, a special thanks to each of you for being a part of this. It's really a privilege. Without further ado, let's just dive in. All right. For the podcast topic, we have optimizing ADT, integrating risk-benefit profiles and patient preferences. And some of the focus questions here are: how do you weigh the benefits and risks of ADT in different patient scenarios? How do comorbidities like diabetes, heart disease influence these ADT decisions? And then what are the sort of latest advances in maybe minimizing the ADT-related toxicities? Who would like to start this one?
I think we all can, we are all seeing those side effects in the clinic, so anybody can start. But I will tell you that when patients were expected to have a median overall survival of 3 years, we really didn't have to worry about cardiovascular side effects. Now, patients are living many years longer. Such a fantastic news for all of us as doctors and patients. But then we are seeing this long-term side effects, which come with muscle loss, leading to metabolic syndrome, leading to this whole metabolic syndrome associated atherosclerosis, cardiovascular disease, strokes, even kidney dysfunction, which happen with vascular pathologies, which happens with metabolic syndrome. So I think there is a whole field of cardio-oncology focusing on patients who are on long-term ADT has emerged. And fortunately, there are a lot of cardio-oncologists out there who really are interested in working with us in improving the lives of our patients. Just one line to add what I do in my clinic right now. I do EKGs. Anybody has suspicion for cardiovascular disease, I order an echocardiogram. But it's much easier to get a cardiology consult after I have abnormal echocardiogram than if I don't have. Hemoglobin A1C, baseline fasting cholesterol, especially when the patients do not have a primary care doctor. I get them done right away and identify patients who are at a higher risk to have these long-term side effects, and I send them to appropriate specialists. That's what I'm doing in my clinic.
I would love to hear from Dr. Smith on this, because I think he's certainly a world expert in bone health as it relates to ADT and has done a lot of seminal work there. Just as a practical issue to follow up on what Dr. Agarwal said is that, I think this is where most urologists are not doing as good of a job as we should. Again, we were not trained as internal medicine physicians, so I think it's a little more, not as common for us to be able to order these cardiac tests. The other thing that's a practical issue is when there were commercially available bone health agents that were actually generic, and we had companies who were calling on urologists about bone health and some of these things, it was a lot easier to keep up. I find that, lately, since really there's no industry people talking about this, sadly, that I think in many urologist offices, it's maybe fallen out of favor, unfortunately. And And again, there's such a shortage of urologists that sometimes this stuff gets forgotten about because they just don't have the time, or maybe they haven't trained their advanced practice providers well enough to work on some of these areas. So this is a great need for us to do a better job.
Yeah, I think that it's really wonderful, I think, to see that there's an interest and focus on the comprehensive care of our patients undergoing systemic treatment. When I began doing research in survivorship almost 30 years ago, the common refrain is like, men don't get fractures, like these are the problems for a PCP. When Nancy Keating, my colleague, published what I would consider the landmark study looking at the relationship between ADT and cardiovascular disease, some of the early journals we tried to publish that the reviewer said it wasn't biologically plausible to be the case. Yeah. So you're like, but here we are 20 years later talking about this as if it's fact, and I think it is. These are real considerations in our patients. And I applaud the comprehensive approach that Dr. Agarwal described in his own clinical practice. And I think that's critical, right? If you're going to be the physician prescribing the ADT, you either take on managing the possible side effects of such treatment, or you appropriately delegate them to someone who will, the PCP or other providers. But ignoring it is really not an acceptable approach. In addition to that beautiful list of sort of baseline testing that Dr. Agarwal described, I thought of, all the patients with PCPs who I've referred back to their PCP or to a cardiologist after their, restaging scans demonstrate severe coronary calcification in a patient who is not known to have coronary artery disease. So like these are like very common. Just a reminder that these are very common conditions, and we really have to think about the whole patient when we're initiating these systemic therapies. And I look at it as like a teachable moment. We're going to have to like step back and say, okay, we're going to have to talk about diabetes, cardiovascular disease, fracture risk in patients who, despite having in some cases, I'd say good primary care, may not be really on top of those issues.
Can I ask a question? When the oral agent relugolix came out, there was some discussion in secondary analysis that the cardiovascular toxicity was less with an antagonist than an agonist. And then there have been some population-based studies that seem to question that. And maybe, in fact, one that I saw actually seemed to suggest that the antagonist had a higher cardiovascular toxicity than the agonist. I mean, I think we need to be mindful for all patients, but is there any evidence where we should prescribe an antagonist rather than an agonist in a patient who has underlying cardiac disease, or do you guys do that?
So I'll take that one if I could. So I find that's a beautiful question, and I'm reminded of those who would say there's no relationship between ADT and cardiovascular disease. So if so, how could a different form of ADT have a lower risk? Like it's like logically impossible, right? So I think the truth, my view is, I think if we could know the truth or reliably, I think what is likely to be the case that ADT of, say, conventional form may modestly increase the risk of cardiovascular disease, an otherwise very common condition in our patient population. And it may be that the antagonists are actually have a somewhat lower cardiovascular disease risk. And that was originally described with degarelix, I'd say in studies that were less robust than in the HERO trial, to look at that issue. So it may be real. I do, in patients who have unstable angina, known problematic coronary artery disease, do like using the antagonist for the hope that they would be exposing them to less additional cardiovascular disease risk, and also that it's rapidly reversible, right? So that in the event you got into trouble, you could choose to stop treatment more quickly.
Yeah, and that sort of made me think of we're not there yet, but there's a lot of discussion about the intermittent ADT and predict, de-escalation and this sort of thing. Does the type of agonist or antagonist sort of play into that if you're aiming to do intermittent, or is it sort of too early to go there?
I mean, the nice thing about, the HERO trial is that when patients were withdrawn from relugolix typically they came back to a non-castrate level within about 90 days, or give or take, whereas it took at least twice as long for the leuprolide to do that. So I've always found that the oral relugolix certainly is ideal for the patient who has a abnormal Artera test now, and where you need ADT, but you only need to use it for, say, 4 to 6 months. The antagonist, oral antagonist, kind of works great in that setting. The EMBARK trial is now teaching us again about intermittent hormone therapy and drug holidays for biochemical recurrence. But I think, I don't know, it'd be interesting to see it. It's weird that, even though we've known that intermittent hormone therapy is a good option for certain cases of prostate cancer for years, it almost seems like it maybe fell out of favor or wasn't talked about as much more recently, but now it seems like it's being rekindled again.
I think it's mostly driven by our shared concerns about long-term toxicities of these potent combination therapies for our patients with metastatic hormone-sensitive prostate cancer. And that's why I think field is thinking about possibly taking a break in those patients who are the best responders, achieving undetectable PSA levels 6 to 10 months after starting these combination therapies. And I think I really applaud all those steps taken by the colleagues across the countries. There are multiple trials which have started or which will be starting looking at intermittent therapy in metastatic hormone-sensitive prostate cancer. Until we have the results of the trial, I would like to reserve intermittent therapy in only those patients who are having side effects which are not allowing them to continue continuous therapy.
All right. Well, I think we've hit this from a number of angles, and anything else on this topic before we conclude?
The only thing I was going to say, it's interesting listening to Dr. Agrawal about de-intensifying when the patients get to an undetectable PSA. But even though I didn't attend ASCO, thematically I was hearing that by the same token, if you have a patient who does not achieve an undetectable PSA by, say, 6-7 months into combination therapy, you want to intensify treatment. So it seems like this undetectable PSA at a landmark period of time is really important. And I'm just curious to hear any further comments that Dr. Smith or Dr. Agrawal want to make about that.
Absolutely. The median overall survival. Again, these are all estimates. And for our patient viewers, I like to give the medians in real absolute months or years. We estimate the median overall survival of patients who are going to achieve a PSA which is undetectable is going to be about 7 to 8 years. And patients who do not achieve a median or PSA response of less than 0.2, just based on multiple data sets, and that's just a real recent Ironman registry-based database presented by Michael Ong, we think the median overall survival will be around 3.5 years in those patients who do not achieve a PSA level of less than 0.2. And there is clearly a difference in this disease types. And SWOG triple switch trial in collaboration with Canadian Cancer Trial Group is hopefully going to address that question if adding docetaxel chemotherapy at that point of time, when we know patients have not gotten a PSA of less than 0.2, is going to improve survival in those patients. Trial has started accruing, is accruing across multiple sites in the US and in Canada. And we really hope that we can finish accrual in this trial very quickly.
Well, thank you. I'll just say it's been a pleasure. I think our audience is going to see all that's going on in the field, across the board, with the research activity and with some of the changes in clinical practice. So it's been an honor. For more on this topic and many others, please look at Organized by Disease State. Please visit our website at expertperspectives.com.